Sorry.
No, no, I was just saying I don't really think it's popular to for a physical therapist I figured it was med school students, so I wasn't I was curious as to what the interest level was. But I don't really think it's popular to.
Oh, sorry. Like
It's okay.
when I went on live stream, it like echoes back. So,
Got
but
it.
sorry. But yeah, we're live, but we'll give it like 2 more minutes. You can finish your thought. I'm sorry.
Yeah, that's
Yeah.
that's all I was gonna say. I was just curious. That's all.
Yeah. Hi guys. Where are you guys listening from today? Where are you guys from? Um, got a few people on here. We're waiting. But yeah, if you see me like having my phone in my hand, usually I'll like record like clips of the session to post on our Instagram. So if you see me doing that, hi guys, hello, hello. How are you guys doing today? Um, but yeah, we'll give it like 1 or 2 more minutes and then we can get started. So what did you major in at U of M?
Movement science.
Yeah.
So that's our like the kinesiology department. So it's exercise science essentially.
Oh, gotcha, gotcha. That's so cool. So are you like from the Ann Arbor area?
No, I'm from Queens, New York.
Oh, okay. Wow,
Yeah,
that's far.
it's good. Got to get away, you know.
Yeah, yeah, I get that. But yeah, I totally understand. But yeah, we can go ahead and get started and we'll let like people catch up as they hop on. But
Sure.
so guys, welcome, welcome. Today we finally have a physical therapist. So for all of you guys who have been asking, we have Ryan Chow, a physical therapist, obviously, like I already said, today. And so make sure you guys stick through the whole session so you guys can watch and submit a summary to clubmedshoot@gmail.com. And then you guys should be able to get a certificate. So without further ado, let's get started. So if you want to just introduce yourself.
Sure. Thank you for having me. I'm honored to be here and speak to some uh, future healthcare professionals. And like you said, my name is Ryan Chow. I'm from Queens in New York City. And I went to school at University of Michigan for undergrad for exercise science. And then I went to physical therapy school on the weekends at Mercy College in upstate New York, Westchester. Um, I've been training. I was a personal trainer between between my undergraduate degree and physical therapy school. So I got a little bit of experience in the field, which I think is really important to do. So getting some real world experience before going to grad school. But yeah, I own a physical therapy practice, which is also a fitness company. So called Reload. And its aim is to bridge a gap between fitness, health and performance, and rehab. So one philosophy that I go by and that I practice on is that rehab is just training while with some pain or while getting over an injury. So in its essence, it's still training. So that's basically the practice I started right out of PT school. I have a staff of 4 physical therapists and 2 personal trainers. And on a typical day, I'm seeing about maybe 5 patient hours, maybe 6, sometimes a little more, give or take. And then I'm managing the practice and running kind of the behind the scenes things there, educating the team and getting everybody kind of moving in the right direction. In my practice, from the standpoint of how many patients I see, each client session is initial evaluations will be anywhere from an hour and a half to 2 hours. and clients themselves, I'll see for an hour at a time. So the reason I do this is I know that most patient visits with whether you're physical therapy or medical doctor or most other people, we don't get the time with patients. So I created my practice with the intention of being able to meet the demands of the modern client of today. So we spend a lot of time getting to know people's concerns, worries, fears, goals, and addressing their health uh, and addressing their goals in the context of each person. So that takes building trust and relatedness. So I really take as much as 2 hours for most people that I meet. Um, uh, on a typical work week, I spend at least probably realistically 60 to 70 hours a week working. 25 to 30 of those hours will be with patients, and then maybe 10 to 20 hours will be on some back end work in terms of administrative notes and things like that. But then lastly, just managing and growing the practice the rest of the time. Uh, and I'll just go down this list unless you want to ask me specific questions and things like that.
Um, just before we go more into like your job now, I was wondering
Sure.
to if you'd like to talk more about like your undergrad experience and like what you did to get into a physical therapy school and your journey through that a little bit.
Yeah. I had probably an unorthodox uh, path from undergraduate to grad school. I went to the University of Michigan, studied movement science, as I mentioned, but I didn't have great grades. So I graduated with a low GPA, which I know is like a death sentence for grad school. So I ended up retaking a lot of courses um, post undergrad while working full time to get my grades up, and then reapply for grad school. Had to take GREs, um, and yeah, I had to get really, I was capable of getting good grades. I just wasn't focused at the time. And when I retook all my courses, I got really good grades. I actually applied to maybe 15 physical therapy schools. I only got one interview, but the people who interviewed me could tell I had a passion for making a difference. My work as a personal trainer showed me how much uh, of pain and rehab was not being addressed through physical therapy or through seeing orthopedists or physiatrists, and a lot of health professionals do their best, but the system at hand is unable to kind of meet the needs of today's society. So I saw this very early on as a trainer when a lot of people would come to me for pain, even though I was only a personal trainer. And eventually, the experience I had as a personal trainer helped shape my physical therapy career. So, yeah, I worked full time. I took classes when I got into grad school as a weekend program. So I did some virtual work before COVID. This is back in 2013 to 2017. I did a lot of class work online during the weekdays, and then more clinical lab stuff I would do on the weekends. And I worked full time while in school, and that helped actually give me. It was a lot of work, but it gave me a head start when I came out to practice.
So, what do you feel like is the most important aspect of an application when applying to PT school?
I mean, realistically, from what I understand, it's, if you don't have a certain GPA and GRE, they're not even going to look at your application, right? So they'll take, if they have 1,000 applications, they take the top, 400 people according to GPA and GRE, because ultimately most schools are judged based on the first time pass rate on the licensing exam. So if they don't think that you're going to pass the licensing exam, then their first time pass rate goes down. And if their first time pass rate goes down, their accreditation to allow people to get into PT school will be in question. So they first have to find qualified students from the perspective of passing that test, and that's probably not what most people want to hear, but that's the reality of the situation. And then from there, I think they'll look at um, your essays. Um, I think a lot of people who read applications all day can see if people are just saying um, very generic things like, oh, I want to help people and things like that, which are true, but they're looking for things that show that someone's passionate about going above and beyond.
Right.
So I think, yeah, I think essays are important in that sense. And then, in the interviews, you gotta differentiate yourself. I think you gotta show that you understand the state of the world, the state of the reality of the professionals who are in in the profession, like the hardships that the physical therapy professionals have, and where the APTA, the American Physical Therapy Association, wants to position the professional. If you have understanding of all these things, you're showing a higher level understanding of representing the profession in the future. So I think showing that initiative is very important.
So going from undergrad to PT school, how much of a learning curve do you think it was for you? And do you feel like there was something that you could have done to like prepare for the workload of PT school?
Um, the learning curve wasn't too bad for me. I think just because I recommend working between undergrad and med school, or grad school or PT school. I think a lot of people who go straight from undergrad to grad school live very idealistically. Oh, this isn't fair. This isn't that. Whatever. Like right now, people in grad school during COVID, like, sure, whatever you signed up for pre-COVID is not what you're getting now. Is it fair? No, but do you have to deal with it? Sure. Just like when you're practicing in real life, not everything's going to run smoothly or go your way. So you got to be prepared to solve problems and deal with things. So I highly recommend working between undergrad and grad school to get a taste of what real world situations are like, to become a problem solver and not, it's not everything is governed by fairness or rules or things like that. Like you just got to step up and take care of it.
Mhm. So, in that, like going off of that, would you recommend gap years? Like, what's your take on that? And
Yeah.
like,
I mean,
obviously,
yeah.
and obviously, like you said that you should definitely get work experience during like a gap year, but like, what else would you recommend in addition to that?
Uh, I mean, I guess it depends on the profession, but me personally, I got into PT because I knew I got to spend time with patients, and spending a lot of time with patients is kind of you have to understand people. So you have to meet people where they are, and you have to be, socially, you have to be able to read into a lot of different backgrounds of people. So I think traveling is great, understanding different cultures, different people, different backgrounds, so you can meet people where they're coming from, instead of forcing people to be to work around your situation. My mentor, Dr. Craig Liebenson, wrote a book that was just published. The third edition was published last year or 2 years ago, and the title of the book is "Rehab of the Spine: A Client-Centered Approach, or a Patient-Centered Approach," and that's what I believe in. I believe that us as healthcare professionals need to cater more to the situation of the client and the patient. So meeting people, traveling, understanding different cultures is just one way you can learn to relate to other people. I think it's highly underrated. I don't think we should all come out of grad school and be robots. Not that saying that's what happens to everyone, but the more diverse of an exposure you have to the world, the more you can talk to someone who may not look or think like you, and still be able to earn their trust and understand their concerns, because ultimately that's what we're trying to help with.
Right. Someone actually asked, so when you retook your classes, did you retake them at U of M or like at your university, or did you retake them at a different university or a college?
I took them at local schools in New York.
Okay.
Um, yeah, so to tell you the truth, the courses I took at University of Michigan were probably like 5 to 10 times harder than the courses I retook. The standards are just very different, and unfortunately, I don't think most schools really care about where you took your courses, meaning they do, but a higher number is a higher number. If you have a 4.0 GPA at a community college, um, it's still better than a 3.2 at a much harder school. And
Right.
at least in my experience, as it relates to physical therapy school.
Right.
So,
Because, like,
yeah.
even like with other professionals, guys, like when we've been talking, they always say that it's better to have like a higher GPA over, like a reputable school. So that's
Yeah.
always so when you were talking about working a job, someone asked what type of job would you suggest working between undergrad and grad school if you're going for physical therapy?
I think personal training is the best possible thing you can do. Just because I spent a lot of time coaching people, talking to people, watching them move, and I can see things. If you have, in physical therapy, a lot of best practices relate around movement, exercise, and things like that. And if you have a lot of experience watching people develop or fail during your programs, you'll understand what to do with people a lot better. So specifically for physical therapy, I think personal training is a no-brainer. Um, I don't know if this is true in all places, but at least in New York, per hour, a personal trainer can get paid, um, very similarly to what a physical therapist does coming out of grad school, which is exactly what happened to me. I was making more money as a personal trainer than I was as a new grad physical therapist, which is unfortunate, and it might be a deterrent to some people, but I think it's important to share these things because um, you can gain a lot of really good experience as a personal trainer, developing exercise programs, coaching people, guiding people, communicating, getting feedback, things like that. I think that's a home run. I think a no brainer.
Mhm. So, moving more into your life now, do you want to talk about more about like how you allocate your time and how does you said you own your own practice and whatnot. So are you always busy? Are you slow? How is your time divided in a day as you go about looking at clients or patients?
Yeah, I mean, I mentioned it, the brief summary of what I said before is I spend probably between 20 and 30 hours a week seeing clients. And
Mhm.
I created my practice so that we can have 2 hour evaluations with clients, initial meetings with 1 hour follow ups. And I do that both virtually and in person. And then I do a lot of back end administrative stuff because I'm trying to grow the practice, which may or may not be for everyone, but I spend time doing that. And then, I happen to also own the gym that I practice out of. I used to rent space from a gym, but now after COVID, it shut down. So now I also run the gym that I used to rent space from. So I actually have a lot of different things, but um, it's been growing. I started my practice 3 years ago, about a half a year after I graduated. So, and I now have a staff of 7. So I have to manage a lot of people. I have to teach clinically. I mentor professionals through First Principles of Movement, which is a seminar series with my mentor on Sundays. So I spend my Sundays doing Zoom calls with groups of osteopaths, medical doctors, physical therapists, chiropractors, and trainers internationally in Asia, Australia, um, US, South America, so Canada, all that stuff. So um, I do a lot, but it's not because I have to. I mean, I could be a staff physical therapist where I work 40 hours a week, but they typically also take home 10 hours a week of like administrative work.
Right.
So I, I do a little more than that, but I think it's a much bigger impact in some ways.
That's pretty cool, honestly, like kind of like dictating your work schedule. But from your perspective, how do you think COVID has affected your practice?
So we're about 50% virtual now. So it's affected it a lot.
Hmm.
Um, when I was a personal trainer, I thought, I did a lot of exercise. And when I became a physical therapist, I would have a license to do manual therapy, learn how to do joint manipulations, massage therapy using modalities. But it turns out most of the best evidence for the most prevalent um, pathology today, disease and things like that are actually best treated with exercise and education. So I actually don't use my hands that much. And I bring that up because that's perfect for the virtual world. So I coach and treat people virtually who can't come into practice. So even though we're an essential healthcare worker and our practice has been open throughout most of COVID, except for the beginning when we didn't really understand what was going on, a lot of my patients who didn't feel comfortable or safe coming in person, I could still work with them online because they were still used to me just coaching them through exercises and taking them through different things. So it has educated the public that physical therapy is actually okay to do through telehealth.
Yeah, that's pretty cool.
Yeah.
So, I see some questions in the chat, and how is your work-life balance as a physical therapist? And if you could go back and do a different profession, what would you have done differently, or do you think you would have stuck to PT?
Work-life balance is good and bad, meaning it's good because I enjoy what I do. I work a lot of hours, not because anyone's forcing me to. I
Mm-hmm.
personally want to grow the brand of physical therapy that I'm pushing because best evidence says one thing, but current practices says another. Meaning most physical therapy practices do a lot of outdated things like excessive reliance on modalities, heat and stim, things like that. Things that are good in the short term, but don't really deal with the problem in the long term. So I'm trying to change public perception and of what physical therapy is. So that's bad because I have to spend a lot of time doing that, but that's good because I enjoy it. So I don't think most people would end up needing to do all the work that I do. So I don't think it's bad overall. If you asked me right out of school, would I have changed my path? I probably would have said yes, because when I came out of school, like I mentioned before, I was making worse money than I was as a personal trainer, and I was spending more time doing it. And I actually felt like I was less helpful because the practices that I worked at, um, they focused on the business model of physical therapy more than the healthcare model of physical therapy. Meaning, I would have to see 4 patients an hour with a physical therapy aide, um, because that's what the practice required us to do, not because I felt like the best healthcare outcomes came from that. So I felt like healthcare outcomes were worse um, than if when I was doing personal training. However, now that I'm in a position where I can influence other people, practice the way I want to practice, and staff people who feel the same way, I feel very strongly about what I'm doing. I feel like I'm giving the opportunity for passionate physical therapists to work on healthcare outcomes, to have a job, and only have to see 20 patients a week, when sometimes some practices they see 20 patients a day. And
Yeah.
if you study epidemiology, chronic pain, we spend $625 billion a year on chronic pain in the US. And that's more than we spend on heart disease and cancer combined, which are the number 1 and 2 reasons for death in the US today. Yet our PT practices aren't doing, we're failing. We're people are in chronic pain and we're not doing anything to move the needle against that. In fact, we prescribe opioids as a healthcare practice, even though we know 140 people die a day every day related to opioid overdose. So we are failing as a healthcare system. So I feel very strongly that I need to continue to do that, and other physical therapists who are passionate about that need to move forward and help with this chronic pain crisis, help with the inactivity crisis.
That's incredible that you're like standing up against these practices. Going more off of that, um, someone asked if you could elaborate more on the business model versus the healthcare model of PT.
Yeah, I mean, look, it's just based on reimbursements and how many hours there are in a day, right?
Mhm.
If it costs you, I'm just making up numbers, right? $10,000 a month to keep your practice open, based on in-network healthcare reimbursements, you would have to see 4 patients an hour to keep the doors open and pay yourself. So, um, the reality is health insurance companies. what in one quarter this last year profited $50 billion in a single quarter, which is $200 billion a year, which means they were making $133 million a day in profits after they paid out all the healthcare reimbursements. So they're profiting off of this model. Meanwhile, patients and doctors aren't getting more money from that. Patients are getting worse care, doctors are getting the same amount of money, yet their profits keep going up. So what ends up happening is the model is set so that these companies will make profits, so that, you know, even when passionate PTs want to help their patients, they can't keep their job and have a salary unless they're seeing 4 people an hour, which means in an 8-hour day, let's call it 7 hours if you have a lunch break, if you're lucky, you know, 7 times 4 is 28 patients a day. I don't really understand how you can teach someone how to do their exercises correctly, the proper dosage, what they should expect to feel, how they know they're making progress, XYZ, all these things, explain to them, educate them about their situation, about what to do, what to expect in 15 minutes,
Right.
let alone actually do the work.
Mhm.
Nor should we have physical therapy aides who don't have any understanding of physiology, pain science, biomechanics, any of these things, exercise physiology, taking over the program and guiding them. Yet that's the majority of what outpatient programs do.
Mhm.
So I don't think you can really have a full, thorough evaluation of a client in an hour or less. And I don't think you can follow up with people effectively. Otherwise, we wouldn't have a chronic pain crisis, would we? If we were so effective the way we were operating, we wouldn't have that problem. I mean, the World Health Organization says 70% of disease today comes from inactivity. Non-communicable diseases make up most of what's going on, and it's due to behavior problems, meaning people don't realize they need to move more. Physical activity guidelines say 30 minutes a day of huffing and puffing and 2 days a week of resistance training. Yet none of our PTs are pushing that. We're reactively responding to pain.
Mhm.
So I just don't think you can change people's behavior in 15 minutes.
Yeah, a lot of these comments are agreeing with you, saying that you're making amazing points. So yeah, there's a lot of
Thank you.
positive. So before we move into the case study, um one person asks, what's the most impactful event that you've had happen to you as a PT, whether that be like a significant like moment with a patient or something that like impacted you.
I mean, realistically, the most important thing that happened to me in my career is I met my mentor, Dr. Craig Levinson, who by profession is a chiropractor, but he is a champion of best evidence, um, best practices. We know that the research says we should do one thing, and these are best practice guidelines, but what's actually implemented is way behind. For example, we know meniscus surgeries in people who don't have locking of the knee are not warranted anymore. In fact, studies don't even say further studies need to find this. We pretty much said that the case is closed. 2 million surgeries for meniscus tears are given every single year, but they're not based on evidence. Um, and this is what he's shown us, and he's taught us the evidence is very clear about MRIs can a lot of times be more harmful than helpful in people with generic low back pain. Yet we give these out at increasing rates. Lumbar fusions have been disproven by science in most cases, but are given out, the rates that they're given out are going up and up and up every single year because there's vested interest. People make money when these things are done. So he's taught me a few of those things, but what he's really shown me is how to keep an open mind for new ideas. He's taught me to practice best evidence and implement, and not just go and do what everyone else is doing just because that's what's popular, because that's not really evidence based.
Mhm.
We understand that you need to de-educate on old, outdated practices before you can implement today's best practices. And that's a knowledge translation issue, is that what we know to be true in 2018, the Lancet, one of the most respected medical journals, released a whole expose on low back pain with internationally with some of the most respected researchers. And it's told us what we should do about low back pain. But if you study what's actually done, it's not being done. I mean, low back pain is the number one driver of disability in the entire world right now. Years lived with disability is 80% of people in their lifetime will in fact experience debilitating low back pain. Yet we're still doing silly things like prescribing opioids, MRIs, and things like that, when most of the time education to keep moving and knowing that most of the time the pain will go away is education, and we almost never deliver that.
Wow. Like I personally am a pre-med and I've never even like considered these things that you're saying. So like I hope like for you guys, like this is like a real eye opener for me personally. Like I didn't even consider like we keep prescribing more and more, but we don't really go into why, like the causes and stuff. So it's really
Yeah,
great educating on that. Um,
yeah.
do you want to hop into the case study? Like unless you have something else to add to what you were saying.
Sure. No, I mean, I'll go to the case study, but just to summarize what I was saying is, it's very helpful to have a mentor um, who's been in the field, who understands what's going on, who still practices, who educates other but still practices, so they understand what it is like to practice today. So that's really the most impactful thing that happened to me. It was by chance. It was because I was working as a student, but I think. Knowing someone who cares and also can guide you is one of the most important things that ever happened. But I will share a case study for you guys.
Mm.
This is a case that I actually presented to our mentorship group of clinicians internationally. Um, so a baseline floor is just basically looking for something that we can uh, address in physical therapy. It's not so much about structural pathology, it's more about function. So yes, 100 different people can have the same medical diagnosis of a knee arthritis, but how it affects each person is completely different. So we need to focus on function, not pathology. So 100 different people with the same diagnosis can have 100 different treatments that would actually help them reach their goals. And sometimes the arthritis, it might not ever change, or it might improve or get worse, but sometimes their function and how it affects them might actually get better without actually improving the structural pathology. So that's kind of a little background on that. This patient came to see me with right neck pain, as well as numbness and tingling in the arm, so possible radiculopathy of the cervical spine. The onset was 2 years ago, and on the left, actually on the left side, he had the same thing 2 years ago. On the right side, it was 2 to 3 months ago that he started having this problem. The MI is the mechanism of injury. So this person used to be a police officer, and he had to give that up because of the debilitating numbness, tingling, and pain and weakness he was getting down his left arm. So he took on an alternative career as working at a famous bakery. And 2 years ago, he noticed after the Thanksgiving rush, where he had to hand a lot of baked goods over a counter overhead, he had this problem on the left side. He eventually got over it, got better. After this past Thanksgiving, the same thing happened, except it was on his right side. So it happened 2 separate years after the same holiday, and which he was doing kind of the same activity. His activity intolerance, which is his disability, the thing his pain, numbness, and tingling and weakness is stopping him from doing, is he's unable to drive for more than an hour without pain. He wakes up in the morning with pain. He can't do his baking job or his police work. These are the things that he's lost because of the symptoms he has felt. His goal is to avoid an ACDF surgery. So that's anterior cervical disc fusion. So they go in anteriorly, and they fuse a disc, and its thought is to change how the nerves of the cervical spine are affecting the arm pain. But a physician told him that he would have to get that. In addition, if he was to get out of his no longer feel the symptoms, he would like to get back to golf and to be able to work either as a baker or an officer. So his physician actually told him that PT would make his pain worse and that he would have to get surgery or else his muscle strength would never come back. This is what we describe as a nocebo. This is a target that I need to, as a client, need to, as his physical therapist, I would need to identify whether this is true or not first. And then, if it wasn't true, educate him on why, even though he's a physician and at the top of the food chain, why that might not be right. Which is, it's a tall task for a physical therapist because we're not seen in the public eye as true experts at this thing. But he really wanted to avoid surgery. So that was the main concern of him. This is what happens when you talk to a patient for 45 minutes before you begin a physical exam, which is why I spend 2 hours with clients. I mean, the studies 15 years ago showed that the average physician cut off their patients in 15 seconds. And the most recent study showed that it's 7 seconds now. So I just let my patients talk to me. I just ask them what they're here for, and I let them talk. And this is what comes back to me. What also came out was that this person has a friend an hour away, and he couldn't even drive to see him because he was afraid that driving was going to make his situation worse and force him to have a surgery because symptoms were getting worse. So these are serious issues that are seriously affecting his life, where he thinks the structural pathology has only one outcome when the evidence says another. And this was his fear. So his past medical history, he recently had COVID. He was fortunately not hospitalized, although now he does feel relatively deconditioned, and sometimes he feels like he's a little bit slow. So he described brain fog, and he can't work out as hard as he used to, as he was as an officer. And then, as previously mentioned, he had left-sided radicular symptoms, which is numbness, tingling, and pain down the arm, as well as loss of tricep strength. For him, his biggest thing that I wanted to address, his primary key link that I wanted to educate him on, is structural pathology is not a sentence for surgery and having a lifetime of pain and all these issues. This is the most important thing that I needed to show him in our first appointment. And simply explaining to him that even though his doctor said this, I believe that isn't enough to convince a person to follow a plan of treatment. The evidence shows that he can recover from this sort of thing, yet his doctor's telling him that, and his doctor is a neurologist and a spine surgeon. So, it's a tough task trying to explain this to him. But I told him that there's a lot of evidence and there's plenty of research studies to show that disc herniations heal. The worse the disc herniation, the more likely it is to reabsorb. Discs are dynamic. It is not something that's there to stay. So like a cut on your arm, if you provide it the right environment, it will heal, right? Secondly, from the standpoint of just his biomechanics, he was lacking left thoracic rotation, which implies his thoracic extension is going to be limited, which in repetitive motions will cause you to have excessive stress to possibly a cervical vertebrae. So what's upstream of the cause of the pathology is actually a lack of thoracic rotation and extension, which is something that you can affect in physical therapy, which in turn will change his symptoms, which in turn will change his pathology without ever getting surgery. And down the road, thinking long-term, is this guy had COVID and he was deconditioned. And he also hasn't trained in a long time. So when the body has a tough time recovering, even innocent tasks like reaching up for something or driving can end up being too much stress on the body because he's so deconditioned. Which, when you look at things from a diagnosis standpoint, it's not on there, but is a huge contributing factor. And MS is a mechanical sensitivity. Things that I asked him to do that causes symptoms to come on. So when I asked him to go through cervical extension, active range of motion, he would have reproduce his symptoms, right? Cervical rotation, same thing. When he did a glute bridge and his with his head on the floor, so just laying on the ground, it would cause his pain. I'll show you what a beast is, but it's basically a quadruped exercise. When he's on one arm, that would cause pain, and I'll show you what a crab is as well. So this is a test of thoracic rotation. You can see his right rotation on the first picture is less than his left, which implies that he can't extend as far in his right thoracic vertebrae based on the biomechanics of the spine. I take these pictures to show him, but also so that you guys can see what that looks like. And so that's just a test that I do to just look at how his body moves and functions. His self-care is basically his exercises, SC. These are things I sent him home with. Training is also the same thing. It's just self-care can be done on a day-to-day basis, like an Advil. Basically, it reduces symptoms with just movements alone. So I told him, if you take 2 Advil and you have pain relief for 4 hours, you take 2 every 4 hours. Instead, you can do these exercises and it'll take away your symptoms, because I tested it and that's what happened. So his cervical extension and rotation no longer were painful after doing these exercises. So instead of relying on meds, these are free. You can do these anytime without any equipment. Training is stuff we're doing in the long term to prevent the loss of function and to build up the things that are weak links that will force him to overstress his neck area. So it's upstream of the cause of the pathology. So I'll show you all these in videos. So this is a beast. A beast is just a quadruped exercise where he reaches his hands, which trains his weight bearing ability through his arms, as well as his core function and anti-rotation. So that was training for him. It was tough for him. I forgot to record this video, but I send these home to them so that they can do it at home. So this is technology, right? You send them home with the video, and it's not a piece of paper with exercises.
So it's more of like they can know how to do it instead of just trying to figure it out from reading it.
Yeah, studies show that if you send people home with exercises and you don't tell them an exact prescription of how to use them, they won't do it. The studies also show that if you prescribe someone with more than 3 exercises, they do 0. So I only gave them 3 because it's overwhelming. You don't know what to do. It's too much, right? So you have to give someone something that's digestible. Sorry. So this crab position is just a position that he holds that promotes of upper cervical extension and scapular retraction, which positionally will take pressure usually off of cervical disc issues. These are more training exercises that I gave him that get upstream of causing excessive stress in the cervical spine. So biceps curls will help upright the spine. So same with the triceps. I gave him specific dosages that were specific to who he is today with the intention of progressing them over time. So I need to give specific coaching cues for each person. So I send them home with I airdrop them their own videos. So cervical rotation, a lot of times in an upright posture, will be limited, but when they're weight bearing through the right shoulder, so the shoulder muscles can act like shoulders, their neck muscles can no longer be compensated. The neck rotation won't be compensated with cervical rotation. So that'll free up their cervical range of motion, which will improve their ability to, let's say, check their mirrors or whatever while they are driving, which is a common complaint. That's work to work upper thoracic extension. Same with this.
And how many times would like a client or a patient need to do these? Like how many days before they started feeling like relief?
You felt relief today,
Oh, like the
day
day.
of.
Oh,
Yeah,
wow.
which is that's how you disprove the myth that you need to get surgery. Because if I did that in the moment, the body is very dynamic. It responds to the internal environment, responds to this external stimulus. So if I did it that moment and it made the symptoms decrease right there, right then and there, then how could it be true that you have to get surgery?
Right.
Unless same thing. This happens with rotator cuff tears, meniscus tears, lumbar disc herniations. I'll change the symptoms right away, and then I'll tell somebody, "Hey, did I go in and sew your meniscus up?" No, then how come it doesn't hurt anymore when you walk up the stairs? The structural pathology is not a death sentence. It does not mean that you have to do a surgery. Yet this is the myth that a lot of people end up coming home with. Not necessarily because doctors are telling them that, but when you only have 7 minutes to explain what's going on, that's sometimes what comes across. I talk to patients for 2 hours or an hour, and I'm working with them the rest of the time. These things come out. It's like, oh, I didn't understand what they were saying, or I didn't understand what that meant. So I just thought it meant this. And people come in with these nocebos all the time, the opposite of a placebo. And I have to identify them and educate them on that in order for their pain and loss of function to return. Because if you have a thought virus that something is going to cause pain to your neck, then you're going to actually do less activity to avoid that, like not driving anymore. And then you will also go into a vicious cycle of less and less and less work, just like this client, which is a type of people I see all the time. This happens every single day. So yeah, people get better right away, and that gives them hope. And when they have hope, then they believe in the exercise plan. So I'll ask him to do this 3 days a week. And if he sees that it gives him symptom relief right away, he'll do it. And that'll lead to progress. But if I hand someone a piece of paper with the 3 same exercises that everyone else is doing, it's not truly personalized, is it? And that's 90% of what happens. People get all these protocols. The people are complex. It's a dynamic system with a lot of interacting multi-system issues. Even studies show anxiety, depression can affect pain. Your understanding of pain can cause pain.
Right.
So all of this plays a role into this. So I educated him that not every hurt equals harm. Just because he feels a little pain with certain activities, it's kind of part of the process. You're going to feel a little pain, but don't avoid every single activity because you feel a little pain. Otherwise, you end up going into a bubble, which deconditions you worse, which makes you move less, which makes your joints, muscles, and bones degrade even more. I mean, this is a endless cycle for an already inactive population, right? So that's what I said. I told them rest is rust, and instead the motion is the lotion. You just got to know what kind of stuff to give them. So I gave him specific things that were challenging that made him feel that movement was the solution. And that's how I changed his symptoms. And ultimately, if you're put in the right environment, your arm will heal, your body will heal. If I have a little cut over here, even if it's a small cut and I keep doing this, it'll never heal because it's not the right environment. But if I leave it like this alone for a while, it starts to heal. And nobody put his neck in a position to heal. So I taught him how to use his exercises from prescription standpoint. I taught him that that's only the beginning. He has to train to build resilience, because if he goes back to work as even, let's say, a police officer, and he does something that's beyond his capacity, then it's the one weak link in his body is going to get overstressed and his symptoms will come back, which is the same thing. It matched his story about his Thanksgiving experience. And I told him that he has to progress everything. If it was hard, he drove from 2 hours away to come see me because he was recommended to. And I told him, look, if you can't see me often, then you need to progress this. Otherwise, the devil is in the dosage. If I give you something that works for you today, but you get stronger in a couple of weeks and you keep doing the same thing, it's not going to work. You need to progress this. And I gave him ways to do that. The CAP is the clinical audit process, which shows that clinically, if I did the things I gave him, the previously painful cervical extension, rotation, and glute bridge things immediately got better. So it tells me that those things were helpful and I got the right dosage. Because if I had him do 1,000 more reps, it probably would have been worse. If I only had him do 2 reps, they actually wouldn't have done anything. So the skill is in understanding where the sweet spot is. So you got to be Goldilocks.
Mm-hmm.
This is something that didn't get better. And because it didn't get better, I would hope that after he did his program and I retested this in a week or two and I saw him again, it would actually be better without any more work. So signs of progress for me, he might still have neck pain with driving, but if he did this next time I saw him and that was better, then that would show that the program's working. So I follow up with all my clients. I debrief with them, good, bad, or ugly, because it's not just what happens in the moment, but it's what happens afterwards. Did they learn? Did they understand? So I texted him, "Hey, how are you?" He's overall good. I felt a little sore, right? Neck feels okay. Not an outstanding home run or anything. And then I asked, did he understand how to use his exercises? So he has motivation to go to the gym, and he understands that he needs to keep training. And this he texted to me. He hit the gym, he upgraded his exercises, and he felt minimum discomfort, and he felt good doing the exercises. Later on, he progressed even further. He saw a neuroradiologist, and he was prescribed meds in conjunction with this to reduce inflammation in the area. And even though on radiologic studies, his herniation is quite big, we know that there's a lot of false positives with imaging, and it may not be the severity of the disc herniation won't necessarily correlate with his symptoms. So you can have really bad disc herniation and have no symptoms at all. There's a lot of studies that show that. There's 75% of people with arthritis in the back have zero symptoms. Same thing with meniscus tears and rotator cuff tears. So MRIs and imaging are not the end all be all of clinical diagnoses, or neither do they determine prognosis as well. So good thing is that this doctor is a different one, supported doing physical therapy instead of the first one who said physical therapy is only going to hurt, and that he has to get surgery. So I'm glad he got a second opinion. Furthermore, his actual disabilities, the things that were stopping him from living his life, were getting better. The most important valued activities to his life, driving, he was able to drive over an hour, and he felt great. So there's progress. So I did all this follow-up to him without ever seeing him, talking to him again. So to the person asking about COVID and technology, it is more evidence-based to follow up with this than to ask him to come in and spend another $350 on another evaluation, when I can just text them and say, "Hey, how are you?"
Right.
I'm not seeing 25 patients a day like everybody else.
That's amazing. Like, you have me fully convinced that I need to like go to a physical therapist for like all of my problems before I go to a doctor. Like, that's awesome.
In some cases, it's appropriate, but I'll tell you, most of the time, that's not the experience. I couldn't even give that experience, even believing what I believe in, working in another job, because that's not what the culture and the priorities of the other practices were. So
Right.
I don't want to make it sound like that's what physical therapy is like everywhere. But I know there's a lot of passionate physical therapists who want to be able to do this kind of practice.
So there's actually a question about the case study. Someone said in the training exercise when he was on his knees, is there any difference if he were to stand up doing those arm exercises?
Yes. Putting him in a kneeling position was done on purpose because it removes the need to have contributions from the ankles. So, which basically forces his pelvis and his rib cage to do most of the stabilizing. So it's a concept based on how babies develop, where babies develop strength and stability in segments. If people have had babies, they know what tummy time is. tummy time, you put someone on their stomach and they're forced to learn stability in their upper body. So it's the same thing as if I had him do the same exercise standing, he might just lean back and forth on his toes and his heels, and he might never get any trunk training. But by putting him on his knees, it magnifies the contribution from the pelvis and the ribs. So he has to have glutes and abs basically stabilize the pillar.
Wow. So there's a lot that goes into it.
Yeah, it's so I don't have to coach it. The position coaches it.
So, just another question that I had. So, do you feel like it is more like financially difficult for a patient to come to you, versus for a patient to go to, someone who does see like 25 patients a day? Like, do you think insurance?
100%. 100%. I only take out on network benefits and charge $225 an hour. There's a million reasons for people not to see me. But most people who come to see me have seen 4 or 5 other doctors already. I already had surgery and failed, but went to another physical therapist. I tried that. I tried this. Most people who come to see me are on their last they're kind of desperate. So yes, there's a million reasons not to see me, but when people are recommended to see me or my staff, they know that we're there to just help solve whatever issues are there. And while it's not necessarily about the money, I wouldn't be able to keep the doors open if I wasn't charging that much, because we give people their time of day that they need. It's problem solving. It's not protocols.
Yeah. Exactly. Thank you so much for educating us and for teaching us so much. Like, I didn't even know about 75% of what you taught us today. So we are all very thankful that you gave us your time. Is it okay if they DM you if they have like any additional questions? So, what's your Instagram handle? Like, if you just want to say it.
Sure. And it was an honor for me to be here and speak to the healthcare practitioners of the future. Whether I don't really define myself as a physical therapist. I just want to help. So, I don't want you guys to think about it as a profession thing. But if you want to get in touch and contact me, my Instagram handle is Dr. as in Dr. Ryan Chow, RyanChow. My practice is at reload.pt. The website is reloadpt.com. And we have a lot of students come in. We mentor a lot of people. We have a lot of people shadow. So if you guys ever in New York, or if you have any questions, just reach out and we'll be happy to hopefully answer some questions.
Thank you again. And yeah, if you guys are in New York and they're taking shadowing, so I would like most definitely recommend that you guys go. That would be very helpful. And just thank you again, like for everything.
You're very welcome.
So if you guys again, if you have any questions, I put his Instagram handle in the chat as well. And don't forget to type up your summaries and send them to clubmedshoot@gmail.com to receive your guys' certificates for this week. Thank you again and have a good night, everyone. We'll see you next week. Good night.